Yes, a little bit from the mitral valve and get to sutureless aortic valves. And Teddy Fischlein is giving the next presentation on sutureless aortic valve replacement in octogenarians, a time-saving solution. Teddy, please.
Dear Chairman, ladies and gentlemen, I'm presenting now instead of my co-worker Ferdinand Vogt because he became father the day before. So we are moving now to aortic valves. The talk today is replacement in octogenarians and a time-saving solution. The concept of sutureless prosthesis has been developed with the aim of simplifying the surgical technique, reducing the implantation time, facilitates minimal invasive procedures, enables concomitant procedures, and also providing a curative solution that means removing the native diseased aortic valve in contrast to TAVI procedures. So these are the three different devices we have on the market today. They enable the Soprano and the Intuity. I will talk more today about our results from the Perceval valves. The advantage of this valve is the valve is fully collapsible in a holder, which you can see here. This enhances visibility, especially smooth and atraumatic valve insertion, especially in very calcified and small roots. There's no need to nut sutures, speed up minimal invasive learning curve, and reduces ischemic time. Now, is ischemic time really that much important? This is one of the first studies from Flamenc group in Leuven. They wrote a paper, Effect of Sutureless Implantation of the Perceval aortic valve bioprosthesis on intraoperative and early outcomes. A prolonged cross-clamp time can increase mortality and morbidity after aortic valve replacement in elderly and high-risk patients. And it's possible to implant a well-functioning sutureless valve in less than 20 minutes. But they did a full sternotomy in 32 cases. Just recently, there's a publication from an Australian group from 2014, also in octogenarians, and they said 30-day mortality rate was 8.3% for patients undergoing aortic valve replacement, 6% for isolated, and in combination with CABG, even 10%. So normally we do for isolated aortic valve replacement routinely a mini sternotomy. And this is a very interesting paper from Ranucci. It's a Milanese group. They resulted cross-clamp time was an independent predictor of severe cardiovascular morbidity with an increased risk of 1.4 persons per 1 minute. So this is our cohort in our institution. We did up to now 232 implants, about 10% redos. We mostly did the J sternotomy, mini thoracotomy, and a full sternotomy in combined operations, mostly with CABG. Cross-clamp time is about 38 minutes. If it's isolated, cross-clamp time is about 33 minutes. And if we look now to the old and younger patient group, you can see if there's a full sternotomy, cross-clamp time in the old patient group is about 49 and 53 in the younger group. And if we do an isolated minimal invasive aortic valve replacement, we have about 30 minutes of cross-clamp time. And under 30 minutes of cross-clamp time, we have about 30% of our patient group. So mortality, this is our log scores for old and young. Mortality in total is 3.8, older group 5.3, especially because of combined procedures with 4.2, in isolated procedures 1.1%. That's the same also for our young patient group. They didn't differ very much, these two groups. Pulmonary hypertension was more pronounced in the old group, pacemaker preoperatively also in the older group. The younger groups had more bicuspid aortic valve, and we also did more redo performances or operations in the younger group. Endocarditis we had in the follow-up 1 case only. So if we compare also Perceval's against, let's say, standard conventional valves, cross-clamp time was about 40% shorter in Perceval cohorts versus traditional valves with a comparable mortality rate, and they had shorter ICU and intubation time. So we just recently published this paper. Does it also result in an improved outcome? The shortening of surgical time, and we concluded that the implantation of sutureless valves is associated with shorter cross-clamp and cardiopulmonary bypass times, resulting in improved clinical outcome. And because we had shorter ICU stay, less ventilation time, and less blood transfusions. So what is the strategy today in our institution? Objective, of course, right therapy for the right patient, always a team approach. Minimal invasive approach is the first choice for isolated aortic valve replacement. And we are using more and more sutureless valves now in, let's say, higher risk groups, let's say, especially in this kind of gray zone patients between TAVI and conventional aortic valve replacement. So, ladies and gentlemen, in conclusion, the sutureless solution increases applicability of surgical aortic valve replacement in the elderly or octogenarians with severe comorbidities. It has the potential to shorten aortic cross-clamp time significantly. The results show advantages for small aortic roots, calcified roots, and redo and combined procedures. It is a major step forward for minimal invasive procedures, and it closes the gap between conventional and catheter-based aortic valve replacement. Thank you very much.
Thanks a lot.
Yeah, there'll be time for one question because this is a mini presentation.
It's still a selected group. You are not using it in every elderly patient.
No, it's, let's say, you have seen the higher log score, and the reason is actually we are using up to now this prosthesis, especially, let's say, in more high-risk patients.
Okay.
Great. Thank you very much. Appreciate it.